Hi, I'm John Lasala, Professor of Medicine at Washington University, and it's my privilege to present to you some of the recent data on left atrial appendage occlusion, and specifically with regards to the topic that is it underutilized. These are my disclosures. All of us are aware that AF-related strokes are extremely debilitating. They're the #1 cause of adult disability. They carry with an exceptional mortality, and 70% result in death or permanent disability. So obviously it behooves us to try to limit these type of endpoints. Anticoagulation is the standard of care, but clearly there are lots of gaps. Despite the increasing risk of stroke, the use of oral anticoagulants and AFib peaks at about 50%. There's about 80% that get some form of therapy in the form of aspirin, but still a large percent of the population is being undertreated. Now, DOACs come into this realm by increasing the number of people who might be able to be amenable to taking this type of anticoagulation. But really what we're talking about is, based on the data, increasing from about 52% to just over 60%. So nearly 40% of oral anticoagulation eligible patients are not receiving that form of therapy. And regardless of your CHA2DS2-VASc score, we can see that there is still a paucity of people that do not have any degree of oral anticoagulation. It's still less than 50%, regardless of the drugs that are being used. So one might be forced to think about the obvious things. We've got issues of poor compliance, we have subtherapeutic dosing, we have a bleeding risk that's still persistent. Why not go to the source of what's causing a lot of these strokes in the patients with non-valvular atrial fibrillation and try to take care of that? Of course, the source is the left atrial appendage, where greater than 90% of non-valvular AF takes place and causing clots to form that lead to stroke. It is seemingly quite reasonable to consider occluding the left atrial appendage for appropriate treatment in these types of patients. We have only one device available to us in the United States. The WATCHMAN device was approved in 2015. We'll talk a little about the succeeding generation, WATCHMAN FLX, with some of its newest data. The Omplotzer Amulet has CE mark from 2013. It's used quite widely in Europe. It has not achieved approval in the United States, but we think that'll take place later on, either within the year. And then there's a couple of other things that are out there and have CE marks as well, like the Wave Crest and Lombre. Lariat's been around for a while, but it really hasn't had any data with regard to randomized trial data reducing stroke. It was just wasn't really approved. It was done as a way of occluding and opposing tissue. That's the way it was initially applied. So why is left atrial appendage occlusion underutilized? A lot of it is very diverse. This is just a small sample. Many people believe that the data is not robust enough. Or they read the data saying it only reduces hemorrhagic strokes, doesn't do anything for ischemic strokes. There's the perpetual conundrum of, should I commit myself to a procedure that might have significant complication rates? We'll talk about some of that and how that's changed over the years. Are the DOACs just as good and safe? And that when you do have a left atrial appendage occlusion, the current recommendation is that people take 45 days of anticoagulation till they have a follow-up transesophageal echo to prove that the device is without significant leak, and then they can discontinue. So some of these patients may have had very, very significant bleeds, maybe intracranial bleeds or repetitive GI bleeds. I can't take 45 days of anticoagulation, so I can't really submit my patient to that kind of therapy. What about the anatomical limitations? Some people fall out of the window for the device. Some people just don't want to have a TE and general anesthesia. What about the costs, the indications? And, as we said, most times AFib is just not treated in the first place. We have a rather generous approval for the use of occlusion. This is, directly from the 2019 ACC/AHA Heart Rhythm Society recommendations. It says for patients who are poor candidates for long-term oral anticoagulation because of the propensity of bleeding or poor drug tolerance or adherence, so all of the things that are leading us to fall off the curve in terms of treating your patients with an anticoagulant, then a WATCHMAN provides an alternative. So it's a rather broad definition, and it's not because of strict guidelines that's limiting the application of the device. So who are the appropriate patients? People who have non-valvular atrial fibrillation, patients who have an increased risk of stroke and are recommended for oral anticoagulation. Patient is suitable for short-term warfarin therapy, as we've discussed, but not deemed appropriate for long-term care, long-term anticoagulation. And patient has an appropriate rationale to seek a non-pharmacologic alternative to warfarin. Now, that's rather broad. I mean, maybe it's your job description, something like that, that doesn't allow you to take it. You're in harm's way where you're going to be subjected to trauma. There's lots of open interpretation about criteria number 4. The current indication for left atrial appendage occlusion in the United States, this is sort of the wheel that looks at all patients. There's an absolute group of about 110,000, relative, over 500,000, and then interested would be over 1 million. But if you look at the number of implants that have taken place, maybe 40 to 50,000 have received these implants at the time of this description. Less than 3% of patients who might be indicated are actually getting a device. So this is a huge disparity based on this appropriate non-pharmacologic alternative and its abilities to produce efficacious outcomes. The trial for approval has been a long, arduous one. It's literally over 16 years, lots of steps along the way. We won't have time to go through each and every single one of them, but suffice to say that we now have 5-year plus data, and that gives us a good foundation on which to base these remarks about efficacy and safety. The 5-year patient meta-analysis of PROTECT AF and PREVAIL. These are well known to most of you out there. There is the dramatic reduction in hemorrhagic stroke. There's also a reduction in cardiovascular and unexplained death, and major bleeding that is non-procedure related is clearly significantly reduced, being off the level of anticoagulation that the non-device patients would have received. As we pointed out, the ischemic stroke crosses unity, so it doesn't look as if there's a particular protective benefit against an oral anticoagulant, but then again, it's not any worse. So it's neutral, which is fine because you don't have to stay on the drug, and you're reducing hemorrhagic and bleeding complications. So we'll go into a little bit more detail on some of these endpoints. This is a measure of the stroke risk versus the CHADS VAS2 score, in which in dots we see the untreated AF arm, and in the solid line, the treated warfarin group compared to the various trials. And you can see that most of them are at least as good, if not better, in terms of their overall outcome and reducing ischemic stroke risk. So you don't lose anything by putting a device in. You may not get exceptional benefit compared to hemorrhagic stroke, but you still have significant reductions compared to baseline of ischemic stroke risk. Even more impressive, maybe, is that the disabled or fatal strokes are approximately 50% lower in the people who received a WATCHMAN versus the warfarin group. And this is clearly a dramatic benefit. If you ask your patients, one of the things they fear the most in any device, any type of element that they're being faced with from the medical standpoint, whether it's a TAVR or anything like that, they fear stroke the worst of all. Bleeding outcomes after left atrial appendage closure compared with long-term warfarin. This is greater than 6 months post-procedure. We have a 72% reduction of freedom from any major bleeds over the 3 adjunctive pharmacologic pharmacotherapy intervals. So a significant, really unquestioned reduction in bleeding problems. But you really want to make sure that you get your patients off anticoagulation. How many people successfully can do that? Well, about 92% at 45 days and 99% at 1 year. Again, at 45 days, that's when your TEE takes place, and you can make the decision that the device is sealed over reasonably well, or if not completely, and whether there's no device-related thrombus, and at that point you can discontinue. But by 1 year, almost everybody is off any kind of oral anticoagulation. All-cause mortality, this has been seen very early on as a signal, just barely statistically significant. Fortunately, it's low numbers, but there is a significant 27% reduction compared to warfarin. Now, of course, through that time course that we showed you, this has been an implant taking place over well over a decade. has it changed as a result of having new operators in the mix? And the post FDA approval registry that all of us participate in clearly shows with 70% new operators, a very high device successful employment of greater than 95%. So a few unanswered questions. What about a randomized trial of looking at left atrial appendage occlusion versus a DOAC in high-risk atrial fib patients? This was looked at in PROG 17. Post-implant, people got 3 months of aspirin and clopidogrel, then a 3-month TE, then clopidogrel would be discouraged with the continuation of aspirin, compared to your choice of a DOAC, but apixaban was preferred. And here you see nice numbers over the span of some 30 months, showing really not much difference between the DOAC and the left atrial appendage occluder, suggesting that we can move to this type of therapy once we have some broader robust numbers to suggest that it's safe to keep people off any kind of a DOAC and or Coumadin and substitute instead aspirin clopidogrel regimens. We'll see that there are some future trials that'll be looking at that. How about the WATCHMAN clinical data for procedural success and safety? I won't go through all of this, but we have an aggregate look at the data across these WATCHMAN studies. Of course, the people fear the most is the perforation rate. This was seen very early on in PROTECT AF. There's a difference in subsequent trials that has significantly reduced the perforation rate. And this is due to some technical features like leading with a soft pigtail catheter rather than a wire. Some other things, just getting familiarity with working in this space has been a tremendous boon to improved outcomes. But the aggregate data is about a 1.3% incidence of pericardial tamponade. The other things were fortunately well less than 1%. Procedure-related stroke, device embolization, and mortality is less than 0.1%. So of course, no procedure is without the potential for complications. This one has become relatively low in terms of those outcomes. And then I'm going to go through some of the final 5-year experience of the CAP and the 4-year follow-up of the CAP2 registries. CAP is the PROTECT AF randomized clinical trial carried out, and CAP2 is the PREVAIL randomized clinical trial that eventually led to FDA approval. Some slight differences in the endpoints, as you can see. We're looking at more specific things in the CAP2 that has not only ischemic, not only stroke, but ischemic strokes, and trying to divide those out. And what you see is that there is a significant reduction in ischemic strokes in both these randomized trials. Now, this is based on an expected calculated event rate on the CHADS FAST2 groupings. The thrombotic events per 100 patient years is cut down by some 70% or more in each of these groups. Now, looking at the hemorrhagic strokes, again, all moving in the right direction, significantly lower than what you saw in Warfarin, and getting better as we go along into the CAP2. So overall, the summary of these would be the procedural success rate is about 94%. Major complication rates within 7 days are in the 1.2 to 1.5 rate. Not too dissimilar than what you've seen, but this is a more robust patient year grouping. Warfarin cessation, again, you can see for both of these, they're giving you 97% in that range, give or take a little, at 1 year in discontinuation. Now, a lot has been made recently about device-related thrombus. It actually has a low rate of device-related stroke. In the chart, you can see that device-related stroke is in the 0.1 to 0.2% range, and the average CHAD-VAS score is in the 3 to 4.5 range. Those people who have a thrombus or a possible thrombus are 4% or less. So those that translate into a stroke is relatively small. Now, what's up next? We have a couple of things. ASAP2, WATCHMAN patients not suitable for oral anticoagulation therapy. We've seen something similar presented, but we'll give you another rundown. The PINNACLE FLX PINNACLE FLX. This is the next generation. Hopefully will be out very soon, later this year. And then concomitant procedures being performed in conjunction with left atrial appendage occlusion. These include at the time of atrial fibrillation ablation, how about during a TAVR, watch TAVR trial, and AFib ablation and LAA electrical isolation with closure. Then the champion AF at the bottom, again with the flex versus a DOAC. So ASAP2, this is looking at closure of the WATCHMAN with a WATCHMAN device, its effectiveness in patients not deemed suitable for anticoagulation. So this continues to be a key point. They can't go on an oral anticoagulant. Suggested dosing is seen here with aspirin and clopidogrel for the first 3 months, and then eventually taping off as the point you get to the 12-month where they're beyond nothing whatsoever. So gradations of dual antiplatelet therapy going to single therapy, going off all therapy subsequently. That's still to come. The option trial is looking at the WATCHMAN FLX as a reasonable alternative to oral anticoagulation following catheter ablation. Here you're going to see AF ablation versus standard therapy versus applying the WATCHMAN FLX and short-term oral anticoagulation plus aspirin. So this will be a very interesting trial to see if it's worthwhile doing this at the time as our EP colleagues are putting in and doing their AFib ablations. Now, the PINNACLE IDE study has just had its data released, so we can review that in some detail. This is to get the second generation device up and running. It has the usual sort of endpoints. Here you can see what it looks like. Its differences. It has 9 anchors. It's not as depth requiring. Some of the exclusion patients for the standard WATCHMAN because there wasn't enough depth to deploy the device. It also covers a broader range of diameters. And there's a minimal exposure of metal to cut down on the device-related thrombus because it has a small healing surface area designed to heal quickly and hopefully without thrombus formation. Here's the comparison of WATCHMAN versus WATCHMAN FLX. You can see just visually the difference in the depth. So we only need, it's about half the device size in the WATCHMAN FLX size. So we don't need a deep pocket for left atrial appendage. That's nice in many ways too, because it also means that if it doesn't have to be as deep, we may potentially reduce the risk of any kind of perforation. The coverage in terms of the ostium diameter goes much smaller and extends even another millimeter or so in terms of the width, up to about 35 millimeters in width. So a greater range of people who can potentially be applicable based on anatomy for closure. The data looking at the primary safety endpoint, this is within 7 days. You can see to the left on the PINNACLE FLX has the lowest event rates taking place, significantly less than 1% compared to the previous data that we've shown you, where it's usually 1.5 in that range based on contemporary data. So it may be that this device, which is easy both to retrieve, more flexible, less traumatic, and doesn't require as much depth, that all of these things are potentially contributing to the lower event rates and provides better safety. The rate of effective closure at 12 months clearly exceeded the performance goal and was virtually 100%. So it's a rare case of having a chance to have your cake and eating it too. Lower event rates with an even more effective endpoint of anatomical closure. How about the use of oral anticoagulant post-implantation? Here, again, most people were discontinued at 45 days. There's a variety of different regimens that were done and used, as you can see here, with apixaban being the primary one, but really everything is sort of thrown into the mix. And about 96% at 45-day follow-up were off any kind of oral anticoagulant. Now, does every patient need a TEE and general anesthesia? So this comes up from time to time. Some elderly people can't tolerate TEE. They may have a stricture, they may have had some problems, some pathology in their GI tract, preventing them from having a TEE. Some just don't like that, and maybe you don't want to necessarily put a few people who have severe lung disease under general anesthesia. There are options, and for instance, one can use intracardiac echo. Here's a case that we did, where applying the device allows us to give a couple of views, not the 4-quadrant view that one usually sees with TEE, but enough to give an idea of size and deployment successfully. Now, the further development in this field is maybe significantly improved by having the capacity for 4D TEE. You can do real-time volume imaging. You can use maybe only one or at most 2 different views to allow an opportunity to see the widths, the depth of your left atrial appendage, and to follow the overall deployment. Here's some interesting examples. This one is being done with a transeptal. We can see the depth of the left atrial appendage, and we can see the width. Now we can do these modeling and go ahead and get the individual dimensions. Very interesting, because this is being done in only one view. We're not going through the 4 standard views of TEE, but we can sit there and measure the appropriate distances and then choose our WATCHMAN device to be some 20% larger than this. So, you know, as things move forward, this may become the standard of care for a lot of your left atrial appendage occluders. And here's a final position and showing any potential leakage. There's a good seal on this particular case. Deployment was subsequently performed. So what's next? Well, we've sort of gone through this. We have seen that PINNACLE FLX is already done, and we hope to see a improvement and move this device into a mainstream therapy. We're looking at people to get oral anticoagulation reduced in their regimen. We want to see as it becomes employed in various different situations, such as ablation, TAVR, and trying to improve and optimizing therapy like ICE, using that as a modality to minimize the need for transesophageal echo and anesthesia. We see the latter components means that this could become basically a single operator implantation. So it simplifies scheduling, and patients kind of like it better too. So why is it underutilized? Have we answered all these questions? I think the data is clear, particularly with the most recent data, that we're seeing not only a reduction in hemorrhagic strokes, we see a reduction compared to untreated patients in ischemic strokes. It may not be better than oral anticoagulation, but it's certainly very, very good. We should feel somewhat relieved by the complication rates. Obviously, this has to be taken very seriously and discussed with your patients as to what those complications are and what the overall percentages are. But we're now seeing complication rates that are 1% or less. You know, if you don't have to be on oral anticoagulation, why should you? Most patients might potentially prefer to be transferred over to a device that doesn't require them taking the risk of an oral anticoagulant and requires them to remember to take it. We are getting away from 45 days of anticoagulation as this data becomes clear. You know, looking into the future, that may be something that's completely eliminated. Anatomical limitations of people who don't really go into allowing us to deploy a device. This should also be mostly eliminated, not all of them, but I'd say 99%. As we now have a device in the Flex that will cover smaller diameters, not require as much depth, and even a larger diameter appendage. We hopefully will get by without using TE and general anesthesia in the future. Cost is always there, but if the benefit's there and there's no complication rates that are dragging us down, then it's usually cost effective. The indications are pretty wide, and I don't know that we'll get more clarification other than to seeing it combined with other therapy. So why not just treat it in the first place? So the clinical summary on the WATCHMAN here, it's a safe alternative. It offers people an effective form of therapy other than oral anticoagulation and allows the vast majority of them to get off taking warfarin and hopefully no X as we see. It has demonstrated statistically superior reduction in disabling, fatal strokes, non-procedural related bleeding, and cardiovascular death compared to warfarin. It has a greater than 95% implant success rate and 1.5% major procedural complication rate that's being even lowered with the new Flex device. And this is including the fact that there are a lot of new operators. And most of the patients, as we said, at not 1 year, virtually 99% of them are off their oral anticoagulation. So I thank you for attention and hope you all have a great day.